Welcome to Between Two Pastries. This is Nicole.
Hey everyone, it's Annie.
Woo woo!
Yay.
Yay!
It's Saturday
All
morning.
right.
Hooray. I was just handed a cup of coffee and I'm like,
Oh, love that.
okay, all
How
right, it's getting
thoughtful,
better.
though. How thoughtful. It's so great, actually.
hmm
Oh, well, welcome everyone. So today we have a great interview. Very excited to talk about this subject. We're going to be talking about teens' mental health, disordered eating, just impacts of life today in general. Such an important topic. Annie and I have talked a little bit about this in some of our podcasts and stuff, but we've just seen such an influx of kids needing assistance, but it just such an influx in disordered eating at
Well,
such younger ages.
and Nicole, I wanted to have, specifically therapists that work with kids or adults, but kids in particular, to tackle this because yeah, we can talk about the food stuff and we talk to kids about their eating disorders or even disordered eating, but like it gets a little murky, right? Like there's a scope
Totally.
of practice, right?
Yeah,
And so I think it's so important to really, bring in have the conversation that like eating disorders are caused by other things
mhm,
going on, whether it be trauma
yep.
or abuse or which was also trauma, or whatever it might be, that's happening. And to have a therapist dietitian combo, you talk about that whole picture with the treatment team, it makes a huge difference. So having conversation, I think, with therapists is so important.
It's so important. It's so important. So, hopefully, we can kind of glean some light on some things today, bring some awareness, and see if we can. I don't know. I don't know if we can bridge a gap today, but boy, we got to talk about the
That would be
subject. So,
amazing if we
yeah, I
could,
know, right? So,
right?
we are going to welcome our fantastic guests today, Miss Heidi Conto. Welcome. Love you so much. And Nate, have not met you, but from what Annie has said, you are equally fantastic. So
I love
really,
Nate.
really happy to have you two on today to give your perspectives and insights on everything. So I'm going to have each of you go ahead and introduce yourselves, tell us a little bit about yourself, and also just for our listeners too, we're going to have all of their information in our show notes. So by all means, these are extremely talented individuals who have so much knowledge and experience that please reach out to them as well. So go for it, Heidi. Looks like you're all ready to go.
I am. I am. Thank you, Nicole and Annie, for inviting me onto your podcast. I love your podcast. I listen to it frequently. I share your podcast episodes with clients
Oh,
that are
that's great.
relevant to them and what they're working through. So thank you for all of what you guys are doing to bring this to our community and just worldwide, really.
Thank you.
So I'm Heidi Conto, as Nicole said, and I have a private practice in Oak Creek. And I primarily treat people with eating disorders, all forms. I work with children all the way through adult. Um, I am, let's see, what else? What else do I do? I am part of the IADAP board, the International Eating Disorder Association for Professionals. I am the chairperson for the certification.
Oh, I'm getting
I
mine.
am, yay!
I know
Oh,
I'm
awesome.
just sorry. I'm not to interrupt you. I'm
Well, Annie, if you need any,
Yeah, we'll talk.
guidance or yep, we will definitely talk. I can help you kind of start the path of
Yeah,
getting the
that's awesome.
SEDS.
Oh,
So
I didn't put it together that was the same person. Okay, got it.
yeah, so
Cool.
I am licensed clinical social worker. I am SEDS certified, so that what that is certified eating disorder specialist and consultant. I do some consulting work with The Manor, which is a residential substance abuse trauma center. So
Mm,
I see clients when they come in who have co-occurring eating disorders as well. And then I also do some consulting work with Inner Haven, which is a PHP IOP program in Madison. So PHP, which I'm so, I'm commonly using the acronyms. So partial hospitalization programming, and then intensive outpatient programming. So that's me.
awesome. Thank you, Heidi. Thanks for being
That's
here.
yeah.
Nate, you were up. You were up.
It's nice to be here. Thanks, Nicole.
You bet.
So, my name is Nate Tratnik. I have been a practicing licensed professional counselor since 2015. done a lot of my treatment through Rogers Behavioral Health, so had quite a bit of experience seeing the inpatient side of things. Definitely a large breadth of varying diagnoses, oftentimes with comorbid eating disorders, and oftentimes seeing a lot of the medical side of those eating disorders too at Rogers. I do some private practice work as well out of a private practice clinic in Wauwatosa, and work with adults and children there too. And I also am now getting prepared to become a PA who will also hopefully amalgamize some of the behavioral health aspect that we see with kind of those comorbid medical issues as well. So I'm happy to be here today and have a chat with all of you.
That's awesome. And
Nicole, if I can just add in really quick, one of yes, working with therapists who specialize in eating disorders, totally great. Nate, you don't necessarily specialize in eating disorders, but actually working with you one-on-one with patients was always incredible because you do such a great job with the kids who have disordered eating or full-blown eating disorders. And you're so knowledgeable on that. So it was always a pleasure to tag team the handful of kids that we were able to do that with. I feel like it was so impactful. It makes a huge difference. So you're so good at it.
I appreciate that. Thank you.
and also just to congratulate Nate that it's a graduation day on some level for you. So congratulations.
Yeah. Big day.
Thank
Yeah.
you. Three very long years,
Oh,
but worth it without a doubt.
yeah, that's so awesome. And thanks for saying yes today, even though it's
Mhm.
a super busy day for you too. So appreciate
I'm
y'all
happy,
being here. Yeah,
happy
thanks.
to.
So let's kick this off. And how do we do this, right? Because it's such a
Mhm.
big subject. As I said, Annie and I have seen such an influx of eating disorder, teens, younger. I mean, it's amazing how
6
young
years
it's
old.
getting. It's
Yeah.
crazy.
Yeah.
As I know you two have probably been seeing too. So, um, I think let's talk about some of the impacts of, okay, why is this happening? Why are we seeing more of this stuff happening? I mean, I'm going to say like I want to pick on social media till the cows come home because it's such an issue, and I just wish there was some kind of regulation with that in
Well,
general, and
let's
there can't
let's break
be.
it up, Nicole. Okay, so prior to social media, what was causing children, and let's say under the age of high school, right?
Yeah.
Because obviously we've got puberty and stuff, but under the age of high school, what was caught prior to social media, what was causing kids to have eating disorders ultimately? I mean, what were some of the primary causes? And Heidi, I don't know if you want to take it away, and in your practice, what did you notice?
I mean, I think before really social media kind of imploded, right? There were still eating disorders that were existing,
Yes, of
right?
course.
And it was just coming through in different forms of, whether it be television or magazines or whatever it might be, right? But we also know that eating disorders have a biopsychosocial link to it, right? And so there are genetic components that come through with having eating disorders. And so I think that forever long, there have been eating disorders that have existed. It's just we have more information, we have more knowledge, we have more assessment tools that are coming through that we're able to just better diagnostically, screen patients, clients, right, for eating disorders. And I love what Nate is doing in coming into the mental health and bridging that with, also treating some eating disorders, disordered eating, because we need more of that medical professional having that knowledge as well. So I think that in response to that, it's more, the kind of imploding of the social media has influenced more of, cases coming to light, if that makes sense.
Mhm.
The social media has been a contributing force to, development of eating disorders and body image dysmorphia. But I think that eating disorders have always existed, right? It's just
Yeah.
we're getting more diagnoses and people are asking for more help, and we're able to, there's more signs and symptoms that people are being more and more aware of. So
Mhm.
yeah.
Nate, do you have any thoughts on that?
I do. I mean, I agree completely. I know that they are actually examining different DNA variations and trying
Mm,
to link certain genes to try and
interesting.
better isolate the genetic components associated with eating disorders. So it's really complex. I mean, I think if we look at it through the microscope of trauma, trauma is a big portion. I
Hmm.
mean, we all
Yes.
at this point know that control so heavily weighs in on eating disorders. And even before the age of people experiencing their trauma through social media, whether it be via cyberbullying
Mm,
or being attacked based on their appearance, having to be on cameras all the time because we're
right.
not in person anymore,
Yeah.
Yeah.
having to always try and find the best angle that I look while I have a frontward facing camera.
Been
Those are
interesting.
just things that
Hmm.
all of us don't really think about.
Hmm. Hmm.
So I think a lot of it really depends on what does my socioeconomic status look like? How hard is the struggle for me? What types of personal traumas have I dealt with even before the age of social media? How hard was it for me to grow up? Those
Hmm.
are just really complex things that I have seen, at least in my professional practice, that have all contributed.
Yeah.
Those are huge. I mean, when you think about it, prior to social media, of course, because people didn't have a platform to really vocalize everything or sit behind something. I mean,
Right.
when you think about it, I mean, think of our diverse populations within, Milwaukee proper, and you think about culturally, it's very hush hush. We don't talk about our eating disorders.
Hmm.
And we can argue eating disorders are primarily a white individual's problem, and they talk about it, but the reality is there's so many people, black, white, Asian, Hispanic,
Hmm.
who are struggling with eating disorders, who are silent because they're
Right.
they're culturally they're told to be silent, or they can't get the treatment that they need. So if you can't afford a therapist, you can't afford a dietitian, you can't afford your PCP, you're just sitting with these problems. So to some degree, yeah, social media is a huge problem, but you swing it the other way, and perhaps social media has helped some people come forward and be able to talk
Hmm.
about their eating disorder a little bit more. I still think it's more negative than positive in any way.
Hmm.
But I wonder if, because now we're seeing this push to really help people who are not primarily white with their eating disorders, and that we're seeing trends of going up and up and up with different cultures and their eating disorders. And is that, again, what came first, the chicken or the egg sort of a thing?
Hmm.
So have there always been eating disorders, or is this new based on what's going on with media and stuff like that?
Right.
So I think, they say the percentage of eating disorders has gone up like 300% in the last couple of
Nuts.
years. And it's I struggle with blaming COVID.
Hmm.
um, but I also know that, you isolate someone, they think about
Hmm.
their problems,
Right.
Yeah.
period. That's why a lot of people
Mhm.
like to stay busy. And
Hmm.
um, unfortunately, people like us, therapists, dietitians, we can't just offer people our services for free. And so a lot of people don't seek out a therapist when they need it. And, putting people in an isolated spot is a terrible, terrible thing to do. And so they have to deal with their traumas. Again, I always come back to that being one of the biggest issues is trauma related,
Hmm.
um, you know, eating disorders or medical concerns.
Oh, definitely.
Yeah,
Yeah.
just on a tangent here. I don't have a question or
Yeah,
anything.
no, but I
I'm
also
just
think,
talking.
going into the whole COVID thing though, in the isolation, and all people have then are their phones, right?
Right. Oh,
And that's
yeah.
that's what I'm saying too.
Yeah.
It's like, and then you have this little mind that is then getting curious about all kinds of different things, and doing that, figuring things out, then self-harm, probably not even realizing that that's what they're doing. But who knows what kind of a situation they're at home, right? Like, are they even talking to mom and dad? Is mom and dad even regulating that? Like, it's a
Right.
mess. I mean, it's just a
Mhm.
mess ultimately. But also, if they're not going to school and they're not, again, what do kids do? They go to school and they compare themselves,
Mhm.
right? Well, they can't be at school to do that, so they're going to be all over social media, and to Nate's
Or
point,
mom, sister,
yes,
brother, dad,
yeah.
household
But
people.
it's very interesting, like to Nate's point too. It didn't even think about that, with COVID came virtual schooling. What a different thing, right? I
Mhm.
mean, kids are already obsessed with themselves and how they look and mirrors constantly, but now they're like faced with it every single day. I mean, that just clicked for me where I was like, oh my gosh, I never thought of it that way.
Right.
Like that's really big. I mean, that would be massive pressure. I mean, I can't even think about myself going to school back in the day and then having to be in front of a camera. I mean, oh my gosh, like to me, I just want to like, whoa, put a
Right.
blanket on.
And I just want to interject here because it's not even just about like the virtual cameras, right? But it was also we were wearing masks, right?
Yeah.
And so when children were, in that transition of going from elementary to middle school, from middle school to high school, right? And they were familiar with wearing a mask, right? And now they have to unveil
Take
themselves.
that off.
And their
Mhm.
pimples and their,
Right,
change
right. And they're exactly, they're going through puberty, they're going through all these adolescent stages, right? And maybe their body weight has changed over that time, right? And so there was just so much for these young ones, right, during this COVID time. So yes, we don't want to get too fixed on, what the outcome has been, right? Because we want to move forward, right? But we also want to validate and acknowledge how difficult those transitions
That's right.
were, right? And that and those were well, like 3 short years ago, right?
Mhm.
That that so much has happened. And so and just the increase with the eating disorder rise and the mental health issues that our young ones are having and adults. But I know we're kind of focusing on
Yeah.
kids here.
So how do you guys work like, so for example, I have a client right now who, I mean, she's a binge eater and, strict binge patterns. And you can tell grew up with a mom who did Weight Watchers because all of her language is very, I have to portion. And it's very Weight Watchers language coming out. And I'm like, dude, you got to stop, get away from mom for a little bit. But regardless, working with her and she doesn't have a therapist and I'm kind of like, hey, we got to deal with some of these other things. And my question is, we work as a treatment team typically at Rogers or facilities and stuff like that. But when you're working with, clients on your own who have eating disorders, how do you manage to, what comes first? What needs to be treated first? Are we treating the binging? Are we treating the past history trauma? Are we, how do we not blur those lines a little bit? And, I'm not going to do any trauma related care,
Right.
outside of, like, we can do food hierarchy and work on fear food, like as it relates to fears around foods, but I'm not going to get into trauma. So, and certainly I can refer, but if a client is not willing to see a therapist, now I feel like we're just in a negative loop,
Yeah. Yeah.
Yeah.
right? So how do you determine what can be tackled first or what came first? Do we got to deal with the trauma or do we deal with getting a person situated on a meal plan?
I
I
mean, I
think
can speak to
often,
that a little. Oh, go ahead, Nate.
go ahead, Heidi. No, please.
I've been talking too much. You go ahead, Nate.
I think really eh, coming back to a part of this, at least it sounds cliche, but there's such an element of control with a lot of the patients we serve that meeting somebody where they're at to allow them to have that level of control with their treatment, I think is really important. So starting and seeing really what's important to you. Where
Mhm.
is the white elephant or the pink elephant in the room? What is most concerning to you right now? Is this something that relates to really your eating being the bigger issue, or do you really want to tackle some of the family issues that predate it more?
Mhm.
I think anybody who's willing to work on themselves is a start.
Mhm.
Oftentimes, a lot of the patients we get inpatient, Annie, aren't that willing to talk about anything.
Mm-mm.
They aren't that
No,
willing to really sit down and have a conversation about their eating or their past history.
no.
So you meet somebody where they're at, you give them an element of control with some of the treatment, and you
Mhm.
start from there. And, if it's financial resources that are a challenge, then, you're kind of in a difficult place because all you can do if you're the dietary part of this treatment team is focus on that aspect and meet somebody where they're at. But that's why I value collaboration so much,
Mhm.
at least with our dietitians at Rogers, because we do have the opportunity to kind of hit it from multiple angles because it is very, very necessary.
Mhm. It is really tough when patients don't want to actually work. You know, they know they need to
Yes.
be there, but it's so uncomfortable.
Yes.
And especially with the kids. I mean, the adults, it's one thing where you're just like, that's your choice. You're an adult. But when it's kids, you really want them to tackle it because the writing is on the wall. You're 10 years old. I'm going to see you at 12. I'm going to see you at 15. I'm going to
Right.
see you at 19. Until you start to tackle this stuff, you're just going to keep repeating, inpatient stays or treatment or running in circles. And so it's really tough to watch that happen. So it's tough. And I really encourage the kids to talk about it, but boy, there's definitely resistance there. It's very uncomfortable. And it's really hard. And I think for Nate and I on the inpatient side, it's hard to build rapport, in a 5 to 7 day period, you're
Right.
trying,
Oh, yeah. Yeah.
like super, super tough. And then they get sent out and it's like,
That's it.
that's it.
Yeah.
Yeah.
Good luck, so
Yeah.
it's challenging.
I
Mhm.
just want to speak about just on an outpatient level of care. I tend to get a few highly acute clients, and with those highly acute clients, where weight restoration is needed to really begin to work on some of the trauma or other maybe co-occurring disorders that are going on. It's really about building a multidisciplinary team.
Mhm.
And Nicole and I have worked together on a few cases, and I really look at it with these acute cases is harm reduction, right? So we want to see, like what Nate was saying, is like, where are you ready to start? Where are
Mhm.
you ready to, reduce some harm to self, right? In the form of your eating disorder, right? So we can start to tackle some of your anxiety. We can start to work around the depression. And with some of that harm reduction and refueling the body, right? And the mind, we're able to really start to see this reduction of anxiety or depression, right?
Mhm.
But with the trauma, I really say we need to heal the brain a little bit nutritionally before we can really
Yes.
start to work on some of the trauma.
Well, and that's my
That's
question,
very
Heidi.
true.
Like
Mhm.
they oftentimes, at least a lot of our medical directors are, yep, you can start trauma related care, do all the CBT stuff, and someone's at 75% ideal body weight. And as a dietitian team, we're like, no, we gotta restore. Like
Yeah.
so I'm curious what are your thoughts on, eh, again, that integration of we got to eat and get the brain healed, which takes a long time, while also having this other group of people who are like, throw exposures at them.
Well,
Um,
it just
challenging.
to your point too, like it overwhelms the nervous system. You are going to get into this locked space. It's going to create more resistance in general. Like sometimes I don't like how these treatment things go. It's because it's forcing something that you kind of can't force on some level.
Mhm.
Anyway, sorry, my
Yeah.
opinion.
Well, and from a biopsychosocial model, I think that it's important to not neglect any one part of the treatment that we're trying to offer to patients. But for anybody who's ever experienced exposure therapy or has gone through an intensive program, you can't do that program successfully if you're not physically well. So I
Right.
don't want to prioritize physical health over behavioral health because it doesn't lie there. But to go through when you are electrolyte depleted or you're hypotensive or you're dizzy and you're falling down and you can't properly think
Mhm.
because your nutrition is so depleted, it's impossible to be present in the way that you need to get something out of those treatment modalities that are
That's
being
right.
offered. So I really think it's important that we're prioritizing some of the physical aspect of treatment, rather than kind of saying, well, but then there's the brain portion too. Well, there is, but that can't happen unless physically we're stable.
Right.
Mhm.
Right.
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 Heidi, I think you were continuing to try to say something when I think you had
I
another
lost
thought.
it.
Oh,
I'm like, I
Sorry,
lost it.
Heidi.
sorry.
No, no, you're good. I
I'm
think
curious too, and maybe if this might be a tangent out somewhere else. So if we circle back, that's okay. I've oftentimes struggled. I tend to work with adults because I don't have to deal with parents. Um, Working with kids, I love working. I would work with our little ones forever. but working with parents is really challenging. I've run into parents where you're in a family session and they say, when is my child going to lose their gut? And they have an eating disorder, but they're restoring weight. And so, of course, it settles and then it'll distribute. And I can explain that, but I really have a hard time biting my tongue when you have parents who they themselves are so disordered. How do you guys handle that? How do you deal with parent populations that are truly affecting these kids? I mean, I just want to take the kid and be like, I'm taking them now.
Oh, it makes me so uncomfortable. Ugh.
Yeah, I know.
I'll speak a little bit about that because I actually work with a lot of parents. I have ran parent groups, workshops for many years, and obviously I see a lot of children, and so the integration of the family is really important in part of their recovery and their health and well-being. And I think one of the things that we really have to keep in mind is that yes, these parents say things that are not, appropriate, or it can be dismissive to a child, or, you know, but we have to remember that those origins of, what the parents are, their belief system and how they see their bodies and how their relationship to food and body weight is, stems from their own lineage, right? And so we have to, well, I help parents to understand their own relationship to their body weight and image, and that, okay, you may have your own relationship to, how you see your body and your relationship to food. And how does that, fold over into the raising of your own child, right? And so being able to explore that with parents, right, and giving them some open-ended questions about, what would you like your relationship to be like with food and body weight and image, right? And how can we be the best model for our children? Because really, right, like what our children see in the home, right, is their first impressions of relationship to food and body weight, right?
Yeah.
And so if there is a parent, and I'm not just going to pick on moms because moms get picked on a
It's
lot,
dads too.
right? It is dads too. But if they're very, overly preoccupied and working out and eating right and having clean, plant-based diets and all of that in their house, right? And they're not bringing in the foods of, that children also need to have experiences with, right? Because when we eat, and gosh, I'm talking to two dietitians here. I mean, when you eat super clean, what happens when your child starts to have more independence? And I see this happen where
Yes.
children, adolescents get their driver's license, and then they're like going through the drive-through because they've never been exposed to it, right? And
And
it's
their
almost
friends are
been like,
doing it, and it's
exactly, their friends are doing it, and and so anyways, I kind of derailed there, but going back to parents, I think that it's just a lot of psychoeducation. It's validating. Are there a few parents that just I get stuck with?
Mhm.
Sure. But again, I always remind myself, like, what has been their relationship to food and body weight, right? Because there is a story there for them.
Of course.
I think we have to validate that. So.
I couldn't agree more with Heidi with regards to education. There are going to be parents that are going to be more receptive than others. Oftentimes, I've found it helpful too to use the framework of saying that this is a really challenging process for everybody involved in your child's treatment, whether it be for mom or dad or grandparents or whoever that person is in that patient's life. And at that time, I oftentimes will even ask parents, have you ever thought about seeking treatment to help manage with all
Yeah.
the stress that is
Yeah.
caused by this? And that opens up a new horizon for them to hopefully get some insight and a little bit of validation with how difficult it is for both the patient and them, to kind of address some of these things. The other thing that I like to try and offer to parents is I oftentimes will encourage them to ask their child, what do you need from me? What do you need from me to do continually? What am I doing that's helpful to you, or what do you need me to change? What about my language do you need to be different? And depending on how open-minded patients are, how ready they are to communicate or voice some of those concerns, that may or may not work. But it's important for parents to know that there are times to fix things and there are times to just listen. So
Mhm.
sitting down and say, hey, is today a fixing day, or is today I need to shut up and listen day?
Mhm.
And you will get parents that will be receptive and you will get parents that will push back. And then it's just unfortunately on the role of all of us as an interdisciplinary team to continue to educate and be patient, and also then be a resource for the patient.
That's such a good point.
Well, and you ultimately end up with two patients, right? Or two
Yeah.
clients. You've got your
Yeah.
child and you've got the parent or
Yeah.
parents. So
Mhm.
it's like two sets of clients that you're really working with. And that can be challenging because sometimes, parents don't realize they're doing it, but it's me, and
Yeah.
my problems, and forgetting that this child is really struggling. And now I only bring this up because I recently presented on it, but let's bring in the element of transgender and eating disorders and the layers involved with that. I mean, it's even more challenging for kids. So we don't have to dive into that. I mean, that could be a whole nother hour that we,
Yeah.
would talk, but
Right.
it's challenging.
Well, and I think that does bring to a good transition, though, of talking about like body image in general
Mhm.
and how we are dealing and working with clients with body image issues. And this is again little kids who are still developing, but also obviously clearly adults. I
Yeah.
mean, I deal with so many adults who I think have severe dysmorphia. I mean,
Mhm.
severe dysmorphia,
Mhm.
So again, there's a wide range of that. And I'm just kind of curious on how the two of you approach that with the different age groups, or what you're finding or anything you wish to share around that.
Yeah. Um, I mean, as we all know, right, like eating disorders are starting younger and younger, right? So, you know, and child like puberty, like children going through puberty is starting earlier and earlier, right? So we'll see parents sometimes say, well, gosh, like I can't believe like, she's 12 years old and she's like, and look at how tall she is. And like, she's really gaining a lot of weight, Heidi. Right. And like, too much weight. And I'm, so it's like, I think those messages, right, are making a huge impact on young children. Right. So again, I really want to stress, any parents who are listening is just really be mindful about your own, fat phobia mindset, around nutrition, body weight, all of that. When you're raising young children, it's so important to just be so cognizant of your own relationship to self and how you're raising your child. Because they are watching. They're watching, right? And so I think that body image is one of probably the hardest pieces to treat in eating disorders because body image issues happen with everybody across the board.
Mhm.
Like it doesn't matter if you have
No.
an eating disorder or not, right?
Mm-mm.
People have whether or not, my I don't like my hair. I have eczema. I have, whatever it might be, right? Like I don't like my legs and my arms, whatever it might be, right? So everybody has something that relates to, disturbances around body image, right? But then it obviously intensifies when it becomes, closer to disordered eating and even eating disorders, right? So it's really about looking at what is your relationship to your body now, right? And what would you like your relationship to your body to look like, in let's say maybe 3 months, right? And that helps us to kind of work from, a framework of a baseline of, okay, this is where you were 3 months ago, right? And where are you today, right? 3 months later, right? And hopefully they can begin to see the progress, right? Like, okay, like I couldn't tolerate, my I couldn't tolerate maybe wearing leggings, right?
Sure.
Because that's kind of a common one. And now, so they maybe have gone from like wearing big baggy pants to now maybe sweatpants, And so it's being able to just find these little body image shifts where they can start to be a little bit more comfortable with what they're wearing, how they're presenting themselves, how they're just, I guess, how they're seeing themselves from within, right? So they can, let me just collect my thoughts here for a second.
Mhm.
So where they can kind of see themselves from within, right? Which is more important than maybe what the world from the outside is seeing them
Right.
as. Does that make sense?
Yeah,
Yes,
100%.
absolutely. I was just going to say, like, as you were kind of talking, it's, my big thing is always like, how do we deal with the distortions around the distorted thoughts around so many different things? And you kind of already answered that in there. It helps when you have this, like, here's where we came from, here's where we're going. It's like they can see, like, oh wow, I thought that way at one point.
I think parents
And
are in. Go ahead, Heidi.
I'll just interject here real quick. I mean, it's a process though. I don't want to
Yeah,
say like this is easy. Like this is years,
right,
right?
right.
But we're taking baby steps as we're going through this process, right? And there may be setbacks through that process, but these are baby steps that, we're helping our clients to see that their image on the outward is. And I know that some of my clients would be like, Heidi, no, but like it's less important than
Nah,
really how I'm showing up in the world,
yes,
right?
yeah,
Yeah.
Yeah.
And I think parents are inherently the firefighters for their kids, right? When I see that my child is hurting or I see that my child is struggling in some way, the natural inherent thing to do is to put the fire out. How do I put the fire out? When I hurt because my child hurts and they come home and they say, oh, I feel so fat today, or I feel like my body image is so this today, or whatever fill in the blanket is, it's easy for a parent to quickly dismiss that thought. Oh,
hmm
well, that's not true. That couldn't possibly be true. That's not this. And then I rattle off a million reasons as a parent as to why it's not true. And I think that comes with the best of intentions, the best of those firefighting skills. But at the end of the day, a lot of that doesn't register, and it comes across as invalidating. So my ask to
Mhm.
parents
yes,
is to pause for a moment and again think, how can I be supportive for my child, whether that means a statement of, wow, I can't imagine how difficult it is to have these feelings right now. I can imagine what it was like to be at school today and to have to sit with this. The other reality of it is kids today are really smart when it comes down to understanding calories, and maybe less as it relates to body dysmorphia. But I've had clients or kids I've worked with who know the back of calorie packets better than most dietitians do.
Yeah.
And they come in and it's like, well, I'm really worried that if I don't have a healthy or nutritious snack today, that my legs are going to be too big. And they're at a perfectly healthy body weight. And I've sat down and I've studied every single snack in the cabinet because everybody at school tells me I need to eat healthy snacks. I need to be
Mhm.
at a healthy weight. So it really is very, very challenging. And that's again where I would ask parents to try and hold back on those statements of dismissing somebody's feelings or invalidating their feelings, and really think about where some of that comes from.
hmm Well, and I also think that that's I mean, isn't that what we want people to do too, is be able to sit with their discomfort.
Mhm.
Just sit, let, like, that it's okay, that we don't have to like make it go away quickly,
But
kind of
that's
a thing too.
weird
And
to
that's such a
people.
nice, it's hard for people, but it's such a, like, to Nate's point of, like, validating that, and then both of you sort of sitting in that, even for the parent, like, it's uncomfortable being like, I need to put this fire out, to his point. But no, you've got to sit with that feeling too, right? It's okay. Let's see what happens with this. Like, because I think so much of, disordered eating too is running from feelings, numbing from feelings, like avoiding feelings, versus, okay, this feeling kind of stinks, but it's also
It's
gonna
okay.
like go away, like it's leaving. You know what I'm saying? And I see a different way of doing things or what have you. I don't know if that's making any sense, but you know,
Well, Nicole, too, just with the body image conversation, I think, from my perspective, doing mirror work and working on body image, there's working on body image, and I really enjoy doing that with clients. And then there's body dysmorphia, and that's
true.
very, very different and very challenging
Sure.
because to Nate's example,
Yeah.
to me, that sounds body dys when it's like, oh God, yeah, that's tough. That kid would be really tough because they're so set. We
Yeah.
probably have some orthorexia going on. That's really tough to manage. But when you've got that kiddo who, I hate this about myself, I hate this about myself, to be able, and adults too. I love working with them on sometimes mirror work, but also, and a plug to our book, but a lot of the stuff that's in there is just, what do you like about yourself?
Right.
And when I've asked, you have doing group therapy and stuff, and or group work, and you ask kiddos or adults that, and they just kind of sit and stare, and I'm like, it could be your eyebrow, it could be your
Yeah.
earlobe,
Yeah.
it could be a cheek, it could be a
Right.
nostril, like
Yeah.
think out of the box here. And you finally get them to say something they like about themselves. And then you ask them, well, what do you like about your neighbor? And they can rattle it off, and the neighbor's like,
Right.
you're lying. And it's like, no, see, these are things that you actually could like about yourself, and having conversation about, and of course it's not comparing, it's more just, this is kindness, right? Like, people think you look awesome, people love you, and getting them to just, realize that you can live in your body and not like it, but also live in your body and really go swimming and be a part of life. But that doesn't mean we have to sit and ruminate. That doesn't mean we have to
Right.
like things. We just, everything, we just, it's neutral, and that's okay.
Yeah.
Because not liking your body really, really seems to limit people
Mm-hmm.
in what they wear, what they do, how they talk, who they interact with. And that's
Absolutely.
where it, again, it impacts their daily life.
Right.
That's where it becomes really a problem. But that bridge to dysmorphia is, that's where it's really challenging.
Right.
100%.
Yeah, and I'll just go ahead and add that when we are working on body image, it is also helping the clients to understand, that I'm not expecting you to get to loving your body, right? And body positivity and all of that, right? That sometimes seems, too extreme for them, right? And so we may just work on like, okay, let's just work on like body neutrality, right? You just learning how to be in your body. And I do some somatic practices and exercises, and really just working from the bottom up, right?
Mm-hmm.
Because they've been so numb, like what Nicole was saying, was just so numb to their emotions, right? And even just the sensations in their body, right? And so
Yeah.
again, when we're talking about like, and actually it is on like all ends, right, of eating disorders, is really about learning how to be comfortable in your body,
Yeah.
right?
Of course.
And just the physical sensations and emotionally.
Yeah.
Yeah.
It's
Mm-hmm.
challenging.
Yeah.
And it breaks my heart. I had a client who, wedding day wouldn't eat her wedding cake. And it's like things like that. And you've got someone who won't go swimming in the summer. And those are the things that really, where it's like, you don't have to live this way. You don't have to miss out on opportunities because you're so, but again, when you're talking about an eating disorder brain and where they're at and they're struggling dysmorphia or body image, it's, they can't do those things. It's really, really challenging. And that's where, if we can tackle it and just create a neutral sense of self,
Mm-hmm.
now we can go swimming with our kids, or we can, go hang with our friends and stuff and smile and enjoy life. And all of a sudden we do like our body for what it does and all of those things. So
Yeah.
it's challenging though.
I've
So
really,
sorry.
oh, go ahead, Nicole.
No, please, Nate, please.
I was just going to say, from a treatment modality standpoint, I've really found some great success with identifying errors in the way we think or cognitive distortions if you present it through the model of cognitive behavioral therapy. And the way that I found a lot of success is presenting it as such that when we do this exercise together, I'm not going to try and convince you that anything that you think about your body is false.
Right.
However, when we talk about it, you need to present it only in the limelight that we're going to present facts only. So opinions don't live in the world of cognitive distortions.
Right.
We need to present factual information. You're going to get a chance to present factual information that maybe supports the thoughts that you have about your body image or what you feel your body is. But then we also need to support factual things that have happened in our life that maybe don't support this cognitive distortion I have about my body image. So I think people then get to live in that neutral mindset again, where I get to examine evidence from both sides of things to really try and come into my own and try and establish that, hey, maybe all these thoughts I have about myself, maybe some of them are rooted in some truth and maybe some of them aren't so much. That really helps the people that don't really live or feel like they're being tricked by all of us. Like you're trying to trick me
Yeah.
into thinking the way that you think, or you're trying to trick me that my thoughts are wrong, or that what I believe about myself is not true. They
Mhm.
buy into it a little bit more, and it's owned by them personally. So when you have a client that's open-minded or willing to work through some of those things, we've seen some great success.
Mhm.
Great points. Great
Such a good
points.
point.
Yeah.
Oh my
Yeah.
God.
So, just in kind of winding things down here and thumbnailing a few things for our listeners, do either one of you or both of you have maybe 3 or 5 things that you would like to leave parents with? Sorry, that's a really big question. Um,
I'm gonna need 10 examples of
I
what
know.
we tell parents.
Well, we've already listed a few really good
Yeah.
things to kind of consider. But, when you think of like, okay, what are some top 3 things to just keep in mind, when we're speaking and working with our kids?
Um, I'll go ahead and share a few things that I share already with my parents that I work with. Um, I mean, I think first and foremost, I want parents to be able to know the signs and the symptoms of when their child is struggling, right? Whether it's with an eating disorder or a mental health,
Yep.
anxiety, depression, whatever, OCD, whatever it might be, right? A lot of eating disorders have co-occurring, right? Diagnoses with it. And so just being able to know the signs and the symptoms, and what some of those might be. If do we have enough time just for me to maybe rattle off a few?
You can do all the things.
Okay. So I think that just really being able to be aware of any sort of like radical changes in your child's schedule or routine, right? What have been some of the changes in regards to their eating habits? Okay. Are they exercising more? Has that changed? Are they doing additional workouts on top of
Mhm.
their scheduled practices or events? Um, I think mood changes, irritability, right? We call it hangry, right? But
Yeah.
there's this irritability that comes with it. Depression, anxiety, if you're witnessing those, um, obviously fluctuations in weight, in either direction. Okay. So, and then I would just say to parents is really being able to come to your child with compassion, really being able to validate, hey, I've noticed you've been struggling lately. I want you to know that I'm here and I will support you however I can. And I want to help you and help all of us to get you the support that you want, right? And really I noticed that when we use kind of that we, right? We phrase it as a we and it's not a you, right? It helps them to feel much more comfortable in being able to open up and talk with mom or dad, right? Um, I would also say that, when signs are, really early on, there is such a better prognosis for our young ones, when I have children working, when I'm working with them, 9 or up, right? I mean, and I'm catching them between almost like this 9 and 12. They're like sponges. They want to learn
Mhm.
and they really do want. I think they're influenced by, maybe what is going on in the family and culturally and socially and everything, but also they have this adaptability to kind of like switch their mindset a little bit more easily than some of my later adolescent clients, and then for sure my adults. So
Mhm. Wonderful.
yeah.
I think for me, a lot of it is first and foremost, validate and listen to your children. Be the role model that they want from you as a parent. And part of that starts with a bit of humility and asking them what they need. I think a lot of this too comes down to trying to reward positive eating behaviors. All too often, I see parents will get angry or will get frustrated or will struggle with any of the unpleasantries of managing a child who is dealing with maladaptive eating habits. But it's really important that you're recognizing and rewarding those positive eating changes or choices that they're making. Eating is particularly difficult because, unlike substance use or any form of addiction, we need to live by eating. I can't not eat. It's a part of the everyday challenge and choice that kids need to make. So when you can highlight and you can reward some of those positive choices they're making, I think that that makes a huge impact on kids. Sitting down and trying to have meals together, having regular family meals, that's something that's really gone away with as busy as, society and people's schedules have become. We aren't in the 1950s where we came home and sat down as a family and ate together. And that really gives you the opportunity to serve as a good steward for healthy eating habits for your kids too. And then I think my last take home point is know that nobody is perfect. This is a learning process for parents and for kids along the way. Stay calm. Don't avoid, the pitfalls that other people will fall into, like blaming or criticizing your child, and be patient and know that there are resources and help if you need them to.
That's
Good point.
awesome. Yeah, excellent
Yeah.
point. Excellent point. And dare I bring up one more little thing just to maybe throw out some ideas around, but there is such a tendency to focus on weight more than behavior. And this is really, really collectively for everybody. So, how do we approach with our kids, even if the parents who are concerned about, like, my child has gained too much weight? How do we help them not say, hey, you know what I'm saying? And focusing on that like it's a negative thing, right? How can we be more weight neutral when really we have just a concern around their behavior, you know? Weight, whether it's too little or whether it's perceived as too much. And I say perceived because as a kid, that is going to happen because that's normal. Really want parents to understand that. But how can we get away from that so much and more like, I care about you and I'm concerned about behavior. I don't know if you're happy, I don't know, whatever. Um, if you're following.
I think it's been helpful sometimes to highlight parents with factual data as it relates to what we really consider health and health care. So a lot of times people get caught up in BMIs and numbers on the scale. But to truly evaluate somebody's health, you can't only look at those, it's multifactorial. Let's sit down and talk about your triglycerides or your lipids. Or let's look at, the status of your health from an actual medical standpoint versus just what I see on the outside of your clothing or the back of the tags on your shirt or the number on the scale. So sitting down and having less of a subjective input and more of factual data to examine and say, hey, look, I'm really concerned because of X, Y, and Z. I'm concerned because your triglycerides are really high. Or I'm concerned because, now I'm worried that this could end up affecting your heart negatively. Your blood pressure is increasing. You're not able to participate in sports the same way. I think being able to look at some of that more factual data is a better lens to view healthcare with than purely somebody's weight. Now, that's not to say that we ignore it or excuse it completely, but that's what I would really encourage parents to start doing and having those conversations with their providers too.
More facts. Mm-hmm. Mm-hmm. Heidi?
Nate,
So,
I struggle
go ahead.
in our line of work in behavioral health because, and you know this, I mean, as a therapist, but now as a PA, we have some new PAs who started, and I get consults constantly to talk to the kiddos about high triglycerides and they just tried to commit suicide 2 days ago, and it's like, no, no, this is not appropriate, right? Like, there's a time and a place to introduce these types of conversations. And I think we have to get the whole medical, industry on board with this stuff, because you're right. Facts are that's what's important. Someone could be 400 pounds and not be diabetic, and their heart is perfect and they're totally fine. And you can have someone who's of normal weight who is a disaster on the inside
Mm-hmm.
and really needs help from a nutritional standpoint, health standpoint, etc. So it's tough because I think, the medical scene, doctors in particular, still kind of rely on BMI a little bit, or weight, and what's going on the outside, and sometimes forget that some of those facts are appropriate or maybe not appropriate to be talking about, especially for kids. And you do have to talk to the parents as well. And so for me, or you as a therapist, to go talk to a kiddo about, you know triglycerides, for lack of a better example, it's just, it's not appropriate in some ways. So
I agree. I think it all depends on where you're at and what point of treatment.
Yeah.
My big point and takeaway is to just look at things outside of just somebody's weight on their scale,
Yeah.
and try and highlight again things that are factual and things that are more digestible.
Yeah.
Talking above somebody who's gonna not hear you or understand the
Mhm.
science behind any of the nutrition, I agree, it is pointless.
Yeah, it doesn't make sense, right? And depending where people at in different levels of care makes a huge difference too. I mean, the inpatient
Yeah.
level is just not the time and the place to rattle off what someone should be eating, like
Mhm.
under different circumstances. So it's challenging in that sense versus the partial level of care, IOP, where it's like, yes, let's start working on some of this other stuff. So uh facts are huge. Feelings and opinions don't get anywhere.
Heidi?
I would just go ahead and add in, I mean, right, the behaviors around food, right, are just our maladaptive ways of coping with things that are going on internally within us, right? And so really being able to again, just coming back to that child, right, or adolescent, whatever, age they may be, and really being able to just kind of sit with them and just saying like, if there's some binge eating behavior that is going on, right? It's just saying, I've noticed you've been turning to food, and I'm wondering if it's for, if you're trying to comfort something else, right? And being able to, and again, I coach parents on, excuse me, some of the language that we might want to use with children and adolescents, and being able to come to them. And I think, again, I challenge parents all the time on just getting rid of the scales, right, in their home. And I don't know that there's a necessity for scales being in the homes, right? And I think when they sit right there in the bathroom or wherever parents have them, right, it's a trigger for so many to just hop on that and see, like, because they're curious, right? And then no matter where that number is, I tell my clients it's going to do something. It's going to, ignite some sort of a behavior, right?
Mhm.
Pills
Mhm.
don't make anyone feel good.
No.
This bad news bears.
Mhm.
Yeah.
Well, this is great. Thanks, guys, for those thoughts. In closing, we always ask our people that we interview what your favorite food is, at least right now. I know it's a strange transition from something so heavy.
So true.
I will go because I don't know where this is coming from, but I am like, I have this like beet craze,
Oh,
like
awesome.
literally beets.
I
Yes.
love that.
I made bread with beets and
Really?
cauliflower, and
Wow.
I like literally will just like eat a beet like in like an apple. Like
Oh,
I'm just,
wow.
yes,
That is
yes. I don't
impressive,
know.
Heidi.
I'm not sure what it is around beets. However, but like I will share like my favorite dish, which is chicken cacciatore.
Historian.
Oh,
So,
cool.
oh
Yeah.
yeah.
So fun.
Oh,
Nice.
Great. Thank you.
mhm.
So for me, because life is so much about balance, I like to balance it between slices of pizza or servings of ice cream.
Yeah.
So it
Yep.
really depends on the day. But you can't grow up in Milwaukee and not love Milwaukee style pizza.
Oh,
So,
yeah.
Yeah.
Absolutely. Do you have a favorite
Right.
kind? We like talking about pizza on our show. What do you have
oh,
Or
I could
plays.
go on for hours. The list is shorter of the kinds that I don't like, Nicole.
Gotcha.
Where do you buy your pizza from? Like favorite place?
Well, I grew up in Cudahy, so I'm a big Papa Luigi's fanboy.
Yep.
Great.
Nice.
Sweet.
That's awesome.
Very
Oh, I
sweet.
had pizza yesterday and the day before that. I probably have it again today.
That's hilarious.
I love pizza.
What about your ice cream? Just because that's always fun
Oh
too.
yeah.
No, it's ice cream's like pizza. Even when it's bad, it's still pretty good.
It's so good. Is it ice cream or do you like custard or frozen yogurt?
I do not discriminate.
So any
Got it.
frozen cream.
Yeah, I'm pretty easily pleased.
Nice.
I like
That's
it. I
very
like
good.
it.
Very good.
Well, this has just been fantastic, you guys. Thanks so much for joining in. It's a great conversation. I really hope people walked away with a few things to consider, maybe a different awareness
Yeah.
around stuff, just anything really. And of course, we always love hearing from our listeners too. So please feel free to let us know what you think or if you have any questions. Again, we will have all of these two lovely people in our notes, so you can contact them, read all about, how awesome they are, and yeah, go from there. So thanks again, you guys, for being here. So, so appreciate it.
Yeah, thank you guys.
Thank you.
Thank you, Nicole and Annie.